The triple anatomical technique for acromioclavicular joint reconstruction. This is a true anatomical reconstruction technique using synthetic ligaments with acromioclavicular ligament reconstruction. Acromioclavicular joint dislocation is a common sports injury in young patients. The aim of modern surgical techniques is to restore the native anatomy and kinematics of the acromioclavicular joint in a biological manner that allows early rehabilitation. Here we describe a technique that involves three key steps. Firstly, the coracoclavicular ligament is reconstructed using a synthetic graft. Secondly, the acromioclavicular ligaments are reconstructed using coracoacromial ligament transfer. Finally, the deltotrapezial fascia is used to secure the overall construct stability. The triple anatomical technique is safe, reproducible, and allows us to restore the normal, stable kinematics of the acromioclavicular joint while allowing early rehabilitation and return to sport. Here we present a patient with a right-sided traumatic grade 3 acromioclavicular joint dislocation. Here we see a diagram of the final construct used in this patient's treatment. The patient is seated in the beach chair position under general anesthesia with an interscalene nerve block. The surgical exposure is achieved with a 5 cm sagittal incision extending from the coracoid to the clavicle. The medial 5 cm of the deltoid muscle is dissected off the clavicle and retracted laterally. Careful dissection is performed to expose the acromioclavicular joint as well as the lateral clavicle. The distal 5 mm of the clavicle are resected using an oscillating saw. 2 oblique drill holes in the lateral clavicle are then created. These match the isometric points of the coracoclavicular ligament. A guide wire is then passed medially under the coracoid and used to load the synthetic last ligament. The ligament is then guided around the coracoid and passed through the clavicular tunnels. The ligament is tensioned while maintaining acromioclavicular joint reduction. The ligament ends are secured with titanium interference screws. Optionally, any excessive medial ligament may be passed around the coracoid a second time. This figure-of-8 configuration confers additional stability. Any excess ligament is then trimmed to be flush with the clavicular surface. Here we see the last ligament transfixed with an orthocord suture. The coracoacromial ligament is then detached from the coracoid and mobilized. The ligament is then reattached to the undersurface of the lateral clavicle using a corkscrew-type anchor. The acromioclavicular joint capsule and deltotrapezial fascia are repaired using a reefing suture technique. The lateral deltoid flap is then reattached. The subcutaneous and superficial layers of the skin are then closed. The patient should attempt to achieve key milestones in a set rehabilitation program. The patient should aim to achieve their preoperative level of active elevation by week 6. By week 12, the patient should aim to have achieved 80% of their normal external rotation. A return to driving can be expected at 6 to 8 weeks, with a return to heavy lifting not occurring before the 3-month mark.